So some of the things that are very, I try to stress this category of drug because dexdomitor has really gained popularity, and I think we use it a lot at school, and I believe a lot of clinics use it. So really understanding, because there's some significant effects. The main thing that I tried to impress yesterday is you have some analgesia, except you should always supplement it's not enough by itself, but it's going to help. And the sedation will vary. When dogs are getting this drug and you guys are sedating them, they're in stage 1. And I told you in stage 1, there's varying levels of sedation from light to deep. And you can use a higher dose to make them deeper. And then you always have some dogs that are a little sedation resistant, and some that are going to be deeper. So sometimes it's related to the dose you give, and sometimes it's the patient reaction to the drug. But one thing that is very significant is the cardiovascular effects of this drug. And some happens when you first give the drug. And I literally wish I could have every patient on a blood pressure monitor that gets this drug right off the bat, because what this drug does is it will cause a massive peripheral vasoconstriction. So all of the peripheral blood vessels that have blood in them get vasoconstricted, they get narrowed. So what happens, all of that blood that was in the periphery gets basically shoved back to the heart, to the core. And so what happens is, the heart's sitting here pumping, and when you get that vasoconstriction, it causes a massive increase in blood pressure. So you get what's called a reflex bradycardia. And what I mean is it's a reflex to hypertension. If you have a massive hypertensive episode, the heart is typically going to slow down. But if you think about it, it does not have to pump as hard because all of the blood just got shoved back to it, and it's hypertensive. So their heart rate will drop. And that is a normal effect of this drug. This is what I tell students. If I'm monitoring a dog and the heart rate was, say, like 120 on its TPR, and now I'm getting 40, because you can get heart rates as low as 40 with this drug. The first thing I look at is, did my dog get an alpha 2? And if it got an alpha 2, it's more than likely that's the reason for the bradycardia. If my dog did not get an alpha 2, I'm very concerned. Okay, so when you get a bradycardia, you have to understand, did it come from my drug, any of the drugs in my protocol? And this category of drugs are the only anesthetics that do that to heart rate. Now, I've told you guys during anesthesia, heart rate does drop, but it drops gradually. It'll go like 120, 108, 96, 92, 87. It just kind of starts to drop gradually. But I'm talking, it was like 120 and then it drops like off a cliff. And then they hover, usually in the first 20 to 30 minutes, they hover in that low heart rate. And it's because those dogs, if you did their blood pressure, would be hypertensive and they're vasoconstricted. It's why when you look at their gums, I told you they're going to look pale. Sometimes you have a hard time getting a pulse ox on their tongue because they're vasoconstricted. Sometimes you have a hard time feeling a femoral pulse or hitting a vein because they're vasoconstricted. And so if they look pale and you gave them this drug, it's probably because of the vasoconstriction. If the heart rate drops, it's because of the hypertension and the vasoconstriction. Now, remember I said in 20 to 30 minutes, the drug starts to wear off. And then what happens is you can start to get a hypotension and a decreased cardiac output. So what's starting to happen is the vasoconstriction is wearing off. So what happens is the vessels are going to start to go back to normal, but that makes the blood pressure drop. Now, sometimes the heart rate will come up a little bit. Sometimes they'll stay bradycardic. That I've seen it different in different patients. But what you just need to be aware of is that, what I try to tell students, because, you're going to look at that heart rate and freak out. What is too low? How do I know if it's too low? And what I told you guys with sedation when I went over that, they should still have a little bit of jaw tone. They should have a respiratory rate above, I like it 8 or greater. 6 is like I'm bordering on my comfort level, you know. Maybe a little bit of blink, but it's delayed. I mean, you should not be able to open their mouth, pull out their tongue, and intubate them on your radiation or your radiology protocol. Okay, so they should still have some jaw tone. They should still pull their tongue back. You could pinch their toe and maybe get a slight withdrawal, But the other thing about heart rate, and I don't know if you guys have noticed this in radiology, a lot of times in between x-rays, you guys are looking at the rads and you might be developing a film and they're laying on the table unstimulated and the heart rate is low. And then when you go to start moving them again, the heart rate comes up, and that makes me more comfortable. If you can bring up their heart rate slightly with some stimulation, I feel like they're in a good, but I've had some patients that are 40, almost bordering a little lower, and I can stimulate them and I get no change in heart rate, then that means they're probably a little deep on this drug. So this is kind of giving you guys, as an anesthetist, when do I worry? So first of all, I'm telling you, they're going to be bradycardic on this drug, and that is expected. Now, the other thing, doctors are 50-50 on this. I will tell you, Dr. Ritz does not like them to go below 60. Dr. Paul is a little more comfortable when they're a little lower. So sometimes Dr. Ritz will give a low dose of atropine. I'm going to go back to those other slides, but I want to talk about this since I'm talking about it. Use of anticholinergics with alpha-2 agonists is controversial. There's like 2 schools of thought. Physiologically, let's think about this. If my heart rate slows down because my blood pressure is high, and then I give atropine, what does that do to my heart? What happens when I give them atropine?
It increases.
It increases their heart rate, and it also means the heart's probably beating harder, right? But all of the vessels are vasoconstricted. So what is that doing to the heart muscle?
It's making it work harder.
Amen, 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 amen. So technically, this is the old analogy I do this in anatomy. I said, what if I give you a Slurpee straw and I hook up a balloon and I say, blow up the balloon. And then I take away the Slurpee straw and I said, give you one of those little cocktail straws, like that stir your coffee. And then I say, now blow up your balloon equally as fast. But now you're like trying to blow through that small straw. Well, straws are like vessels. So if I have a blood vessel and I vasoconstricted it, but I'm telling the heart, well, pump faster and harder, but it's trying to pump out of this little straw, you're increasing what's called myocardial oxygen consumption. Anytime the heart works harder, it needs more oxygen. These animals are not breathing as often or as deep. Not that they're hypoxic, but this can set up arrhythmias and this can set up problems. So there is a school of thought that says if your dog's in trouble, like really bradycardic, like you're concerned, it's better to reverse them and potentially have to wake them up. I know at school, Dr. Ritz will give them atropine, but she's using a low dose. It's like a quarter dose of atropine. When I was trained under an anesthesiologist, I'm teaching you guys what I was taught by an anesthesiologist, and he worked at U of I where they developed dexdomitor. So he was part of that school and part of that, so I was trained by one of the doctors that helped develop this drug when it came out. And when he trained us, he preferred to not give atropine. You could either let the drug wear off or potentially reverse them if they are in trouble. So I'm just telling you, if people are concerned, there is a safe way you can give them atropine, like 10 to 20 minutes before you give the dexdomitor. That's a little bit safer. Then you're not really supposed to give them together. You know, they don't want you to give atropine and dexdomitor at the same time. And giving it after the dexdomitor is kind of but I will say at the school we're using quarter dose, we're using low dose atropine. So hopefully, you know, I'm just kind of telling you where people are coming from, and you guys might work with doctors. Like I said, at the school, you know, Dr. Ritz and Dr. Paul have different comfort levels. The doctor I worked with in oncology, she did not love dexdomitor. She's like, I hate the heart rates. And I even explained to her, I'm like, you know, this is why it's happening. This is why the heart rate is what it is. Physiologically, there's a reason for the bradycardia. It's not because it's a side effect. I mean, it is a side effect, but there's a reason it's happening. That's what I'm getting at. So you have to have an open mind. I'm giving you guys all of the information, but I'm also telling you that no other drug that I talk about besides these drugs does that to the heart rate. Okay, propofol doesn't do it, ketamine, ACE, midazolam, torb, morphine, none of those drop the heart rate like these drugs. So that's a key difference. And that's why I want you to know. Now let me go back and I'll come back to that in a second. So probably the most profound effects are to the heart, to the cardiovascular system. You do get what's called dose-dependent respiratory depression. They're sedated, they're going to breathe less. And I've already told you 6 to 8 breaths a minute is like my low absolute normal. If they're breathing like 4 times a minute, they're pretty deep on this. You know, you might have to have oxygen nearby, or, you know, watch them a little closer. You get good relaxation, and it potentiates the other drugs. I will say, the days I helped in surgery and they used dexdomitor, torb as their IM pre-med, those dogs are well sedated. They were like zonked, that's what I want. If we're putting in a catheter and I'm getting ready to induce anesthesia, I want a very calm patient. So it works well as a pre-med. You do need to know, and I don't know if you guys have seen this in radiology yet, 50% of dogs will vomit with alpha 2s, 90% of cats will vomit. So I don't know if any of your cats have vomited like after you sedated them, or, you know, on recovery. Most of the time it happens after you give the drug. But it's pretty reliable emetic. In fact, I'll talk about xylazine in cats, and you can get some hyperglycemia initially, but it can go away. And they will get hypothermic. They're, you know, but then I do talk about the vomiting probability. So in the ER, if an animal comes in and they've ingested a toxin, you know, Tylenol, chocolate, grapes, you know, cats like to eat poinsettias and lilies. You know, if they come in, dogs, we typically give a drug called apomorphine. And when we give it, they vomit usually in about 15 to 30 seconds. It's pretty instantaneous. In a cat, it's preferable to give them either dexdomitor or xylazine because it's that predictable. So sometimes in cat, now you can use apomorphine in cats, but they're a little sensitive to the morphine component. Some people will use dexdomitor or xylazine as an emetic. So again, if your cat eats a lily, you know, cats don't typically get into grapes and chocolate or onions, but, you know, they like plants and they like pills. So, you know, that's something to be thinking about. Now the CNS, they should be calm. They should be sedated, but you can get they can feel a little bit out of it. So you have to be cautious when using this. I'm always kind of aware, you know, and so far, guys, all of this pertains to both agents. Everything I'm talking about pertains to xylazine and dexdomitor. I talked about the cardiovascular and the respiratory depression. Again, this is a potent sedative group. So potent sedation, more respiratory depression, more CNS depression, the cardiovascular effects as well. There is sometimes some increased urination, but depending on your patient, unless you had like a urinary blockage, you monitor urination, that can just happen. There are some reports of it causing potential for bloat. I have not seen that. There's just some reports in the literature. You can get excess salivation in cattle. Sometimes cats and like brachycephalics, I see that as well. It is contraindicated in cattle. Now, this would be xylazine, but if you were using dexdomitor, if they're in their last trimester, it can cause spontaneous abortion. So in cattle that are pregnant, it would not be a drug of choice, so we don't want to cause any. And it can cause some sweating in horses, because remember, horses are the only species that really sweat through their skin. One thing that you have to be aware of, and I always like working in veterinary medicine because I feel like we don't have to worry a lot about getting stuff on our skin or things. This drug can get absorbed through mucous membranes, or if you accidentally inject yourself, you will become sedated and you will become bradycardic. So if you accidentally squirt this, especially if you had an open cut, if you got it in your mucous membranes, you need to wash it off, especially if you're working in large animal and using the large animal xylazine, which is a higher concentration. It's going to have a more profound effect. So this is one drug you do not want to get in your eye, and you got to wash it off immediately, wash out your eyes, clean out a wound if it gets in your wound. So be cautious. Now, this drug I like this drug for your everyday happy, healthy patient, elective procedures, adult patients. If they are in any of these categories, any type of illness, pregnant, pediatric, geriatric, it's probably not going to be the drug of choice. I do want to say, I've told you this before, if you're going to use it in an older patient, I would use a very, very low dose, or pediatric or nil patient, but I'd probably choose one of the other sedatives. Remember, if you have 3 sedatives available, midazolam, dexdomitor, or acepromazine, if I got a geriatric patient right away, I'm probably choosing one of the other drugs versus this category because, and again, let me make a disclaimer, age is not a disease. I anesthetized, it was an 18-year-old shepherd mix, and she had proof. This dog was 18, had a brain tumor. I had to do 16 anesthesias on this dog for brain radiation, believe it or not. That dog was like textbook anesthesia, like was better than some of my middle-aged patients. That dog did great. I treated it with kid gloves. I was very careful, but they can be old and still be healthy, but I'm just more cautious because everything is older in an older dog, older organs. And sometimes you worry, are there disease processes we have not picked up on? So some heart disease in dogs can be what's called subclinical, meaning they have disease, but if they're not clinical, they're not showing symptoms like exercise intolerance, coughing, difficulty breathing, weak pulses. So sometimes we pick things up on accident, but their dog wasn't really showing any clinical signs. So you're just always cautious. And this drug, not my favorite in those types of patients. I've already talked. And the other thing, and I think at the end of the call, I was talking, someone, maybe it was Sean, you were telling me that you guys saw the reaction to loud noises where a dog, the animal will be laying there like they're super chill asleep. And then all of a sudden they bop up and they're like, oh, hi, I'm awake now. And then I go back to sleep. Have you guys seen some of that?
Yeah, that was me.
Yeah. And I mean, it's very odd when you see it, but the thing I worry about, and when I've walked around the school when people are sedating in surgery, I walked by a surgery table. Their dog actually fell off the table. 4 people were standing around that dog, but they all had their back to the dog, and he was laying there asleep. But something startled him, and then he jumped up, and nobody could react in time. And luckily, he didn't break his jaw. I've walked by the radiology room, and everybody's over looking at a film, and the dog's laying on the table, and I'm like, "Hello, nobody has their hand. What if I walked in that room and I said, 'Hey,' and then the dog, woo?" And so somebody always has to have a hand on a sedated patient. I mean, no ifs, ands, or buts. I mean, that's just standard because, like I said, you never know when something's going to make a noise. Radiology machine is noisy, clicking and beeping, and sometimes the beep, and then they go back to sleep. So there is some sensitivity. And I will tell you, and sorry I beat this drum to death, but if you get bit by a sedated patient, they don't usually let go. And the problem is they don't know what they're doing. They're just reacting. So if they act aggressively, a lot of times they're not with it, but they don't like to let go, and that's worse. So anywho, just be very careful. Always be around them. Now let me talk about a couple of the differences. Everything I explained to you is effects of alpha-2 agonists in general. Xylazine was the gold standard. It's known as Rompin, so you need to know the trade and the generic. It comes as 2 concentrations, which is important. There's a 2% solution. Now, you remember from pharmacology, sometimes you guys will order drugs and the mgs per mil is not written on the bottle. It just, lidocaine comes as a percent. You basically add a 0 is the short way. So if it's 2%, that's 20 mgs per mil. If it's 10%, it's 100 mgs per mil. So there is large animal xylazine and there's small animal xylazine. Sometimes you get sent the wrong bottle. I already explained, BCA, we carry both. Because if you have a very large dog, you can use the large animal xylazine and give a smaller amount. But we keep it locked up so that you don't grab it by accident, and some clinics will put them right next to each other. They're like, well, here's where the xylazine goes. I usually try to mark the bottle with like a pink sticker or, say, put a big LA on it so you know it's large animal versus SA. You can do whatever you want. As long as you are aware it can come as 2 concentrations. One thing to know is cattle are extremely sensitive to it. Like, for an example, if I had a horse that weighed 1,500 pounds and a cow that weighed 1,500 pounds and they were both 10 years old, so same age, same weight, and the horse was going to get 2 mils, the cow would get 0.2 mils. That's 1/10 of the dose. They are that sensitive to it. So, I said you have equal body mass, equal age, and I have reduced the dose by 1/10. So that's a pretty low dose. So cattle are very sensitive to it. And especially, like I already said, it can cause spontaneous abortion in cattle. So we don't use it if they're pregnant, especially the last trimester. So, but this is mostly used nowadays in large animals. Some people will probably still carry it in small animal. The one thing I want you to know, it's less receptor specific. So when you give xylazine, it's going to bind to the alpha-2 receptors, but it's not as specific for it, which I'm going to talk about dexdomitor. It does have a reversal agent, which is yohimbine, which is the trade name. Now, funny way that I told students to remember this, or this is how I remembered it in school. I said, yo, him be awake now. Is nobody going to laugh? That's funny.
Gillis told us that you said, yo, him been sleeping too long.
Gillis. Yeah, no, so I used to say, because guys, this is how I passed tech school. I had to come up with, my brain does not memorize things. I am not that. Sometimes people are like, oh my God, you sound so smart. And I'm like, when I was in your shoes, I was busting my butt thinking of weird, stupid, funny things because this brain does not just, you know, some people got that brain, they could just memorize it. If you can memorize it, fantastic. But I told that to my students several years ago, and one of the students came to me and she's like, that was on the board exam, and I remembered it because of what you said. And I said, I've done my job. I've done my job. Yohimbe Awake now. But these drugs are specific, these reversals are specific for their agent. So Yohimbine reverses xylazine. So I do want you to know them kind of as a group. You have the agonist. Now, when you give Yohimbine, it will go to the alpha-2 receptors and kind of like bind, knock off the xylazine, and reverse the effects. And it blocks further effects. So you do get some blockade, but you know, they should wake up. And the reversal is fairly quick. Now, dexmedetomidine is the generic dexdomitor. Now think domitor sleep. Dormir is Spanish for sleep. Domitor, if that helps you, dormitory, sleepy, sedation.
That helps me, but I always want to put an extra R in it.
I know, me too. It bugs me that it's not dormir exactly, but that's kind of my connection, was like dormitor, dormir, sleep. And so maybe that's kind of how they came up with the name a little bit. I don't know. But this is more used in dogs and cats, and you get sedation and analgesia. The difference is it's more potent and a little bit safer than xylazine. It binds to the receptors better. So it's more specific. So you can use a lower dose. Okay, when xylazine goes in, some of it's going to bind and some of it is, you know, so you use a different dose than you would for dexdomitor, because dexdomitor is better at specifically binding, and then that helps dose reduction. So that, I do want you to know it's more potent, you know, better reliable sedation, safer than xylazine. I mean, it still causes a lot of the same effects, so you still have to use it cautiously. And then its antagonist or its reversal agent is atipamezole, which is antecedent, anti-sedate. So Yohimbe Awake, I'm anti-sedate now, antecedent. So antecedent is specific for dexdomitor. Now, if you are working at a clinic and say you had Yohimbine and you say somebody threw out the antecedent by accident, you needed to reverse a dog and all you had was Yohimbine, you could use it. You may not get full reversal because it's not specific for that drug, but you can cross use them in an emergency if you had to. But I do want you to know for the test, Yohimbine reverses xylazine, antecedent reverses dexdomitor. And I will tell you, there is a dose, like if you look up the reversal agents, there is dosing, but, and this isn't in the notes, but you just draw up equal volumes. If you give your dog 0.2 dexdomitor, you're going to draw up 0.2 antecedent, and the same for xylazine. So, you know, I mean, a doctor could calculate it, but most often what we do is I just draw up the reversal and have it, you know, on standby. I always draw up the antecedent and I kind of keep it in a separate spot so you don't accidentally give it. You know, the bottles are different colors. Dexdomitor is of like a blue, aqua blue color, and antecedent is an orange bottle. So they have the same looking label, different colors. So that kind of also helps me too when I use the drug. You know, it's pre-anesthetic. That's why I'm talking about it. You can use it in other protocols like Kitty Magic, and it can be it can be part of an induction protocol. But the way you guys are using it in radiology, it's a sedation protocol, and it does have bradycardia. The other thing I will tell you, it is more expensive. So xylazine's been around forever. It's much cheaper. Dexdomitor is still fairly expensive. So cost is a, you know, I'm trying to teach you guys what's different about the drugs. So I talked a lot about why they're the same, but what makes them different. And that price, receptor binding, safety, species, are the two differences between the drugs. Now, let me talk about the antagonists, which reverse all the effects. Now, anytime you reverse a dog, and maybe you want to take away bradycardia or respiratory depression, you're also reversing the good. You're reversing sedation and you're reversing analgesia. So some dogs will wake up and sometimes potentially could be aggressive, could be snapping, could be overly excited. You know, it's just something to be aware of. And they wake up fairly quickly. Now, most of the time when you're reversing them, you might be doing it because they're too bradycardic, or you're done with the procedure and you want to wake them up. Now, they are fairly safe, but let me talk about if you gave too much antagonist, if you overdosed an antagonist. Well, you're going to get the opposite of sedation. You could get excitement and muscle tremoring, because when that muscle activity returns and when that excitement returns, you can get tachycardia. Often their heart rate's going to go up if you give too much, and you could get some salivation and diarrhea. The other thing that happened, when I was at Purdue, we had dogs to sedate for radiology for orthopedic films, and the students would drop their drugs, and I was watching like 3 different cases, and they gave the drugs to this dog, and he's, you know, it's 20 minutes and he's panting, looking at us, kind of salivating a little bit, took his heart rate massively tachycardic. And I'm thinking, like, why are you not going down? The other dogs were asleep, getting x-rays. And I'm looking at this one like, and then it's like 30 minutes, still tachycardic, panting. So I called my anesthesiologist and I'm like, this dog is just, you know, I don't know. I could give it some more drug. And then he goes, did you guys accidentally give the reversal agent instead of dexdomitor? Because he goes, he's looking like you woke him up. And when I asked the student and he looked at the bottle, he was like, I could have grabbed the wrong bottle. And so if you accidentally give the reversal agent, you're going to see potentially, you know, pacing, tachycardia, maybe some drooling. This dog was pacing. We just had to wait because now the antagonist has already bound. You'd think you could give the agonist now and get the opposite effect, but it doesn't work that way. We waited, we just postponed it, did it the next day. He ended up doing fine. So I do want you to know that, you know, there are some effects of the reversal agents. Now, don't worry about the ratio agonist to antagonist. It's equal dosing. But what I want you to know is that most of the reversals that we do are IM. Have you guys reversed any patients in there?
Yeah, we reversed our animals in radiology.
Did you give it IM?
Yes, ma'am.
Okay. I mean, the only time I'm not a fan of IV reversal, just because you go from like completely asleep to like, well, hello world, where have you been? Yeah, I mean, it can cause a lot of excitement. I only use IV, my personal belief, and our anesthesiologist, like I said, I'm going by what I was trained, and it was IV reversal was really preferred if they had an emergency. If this was a convenience thing, you know, they can wait. You know, they're gonna, and sometimes they can wake up fairly quickly. But let me also tell you guys something. If you have these animals down for 45 minutes to an hour, they're probably going to wake up fairly quickly anyway. There's a lot of patients we don't reverse. We just let them wake up on their own. You don't have to reverse them. And, you know, if you've got the lady up front that just wants her dog because she's impatient, I mean, sometimes it's a client. It's a convenience. Like, I just want to get my dog home. We want to get him out the door, you know? And so, but there's just some effects, you know, you're going to get some cardiovascular, some sympathetic stimulation and tachycardia, maybe some excitement. So I prefer to let them, number one, I like to prefer just let them wake up. Just put them away, let them sleep it off. Next would probably be IM, and then IV should be emergency, in my, in my opinion. And my opinion's all what matters in this class because I'm teaching it. So anyway, if it's been, oh, this is the other thing I want to mention. If it's been longer than 30 minutes since you gave the drug, like you guys in radiology, it probably takes at least 30 minutes to take your x-rays, maybe 45 minutes to an hour. You don't have to give all of the reversals. Sometimes we give half. So say you drew up 0.2 mils, but it's been 45 minutes, you can give 0.1 mil. You can give a partial reversal. Just because you drew it up doesn't mean you have to give it all. So I am also a fan, and sometimes I've seen doctors do half IV, half IM. So they do a partial IV reversal. So, like I joke, there's many ways to skin a cat. I'm just giving you guys the information of the pros and cons of the routes, and I want you to be able to say on a test, what are disadvantages to giving it IV? Why do we give it IM? So I'm explaining to you the pros and the cons of why we do it. Now, yohimbine reverses xylazine. It's equal volumes. You can always check with your doctor to confirm. And then your atipamezole is your antecedent. And I have some notes here. IM, IV if it's an emergency. It talks about half the dose in cats compared to dogs, but that kind of depends on the patient. I've used equal amounts in a cat, but you will see some patients. Sometimes it depends on how good your muscle stick is. Now, I think a lot of students, especially when I was in surgery, a lot of people like to use the back leg muscles, the semimembranosus tendinosus for injections. I've been having the students do epaxial injections up in the back muscles because, and I think you get a better stick. There's a better muscle group, better blood supply. Plus you're not worried about that big nerve going down the back leg. But the students, even my anesthesia students that are in surgery, they're like, oh, that was fairly easy. And these animals it's more predictable. So, you can see reversal as soon as 5 minutes via the muscle. It kind of depends. The colder they are, the deeper they are, it'll take them a little bit longer to wake up. So there is a little bit of patient factors in this as well. So, okay. Do you have any questions about dexdomitor, reversal? We're going to talk about the opioids, and then this test is really going to stop at slide, looks at like slide 62. So really this test is only covering the pre-anesthetics. So my goal is to kind of finish this up tomorrow and talk about a plan. Do you have any other questions about that? This will be the PowerPoint that we use when we start the next group of drugs. So remember, this PowerPoint, there's not going to be like a new PowerPoint. We're just going to move on where we left off. So
Are we going to go over our homework then as well tomorrow too?
yeah, I will cover some of that. Yes. And hopefully everyone found their drug information okay via the sources that I gave you. So, okay.